Okay, today we are talking about pump failures, and now we're going to demonstrate a pump failure on a Cardiohelp system by Gedinga. Let's give you a tour of the circuit here. We have our patient over here, and they have a venous line, and this is our simulated venous cannula, providing some resistance to getting fluid out of that bag. We're draining fluid down the blue line. It's coming over right in here past the sat-cret monitor, going in and around through the pump and across the oxygenator in this direction, and comes out the other side. Now it's arterial blood. It's getting its gas over here. We have sampling. We have sampling here before the oxygenator. We have sampling after the oxygenator, and again after the oxygenator over here. These two are often used for crisis management. All right, so 3 pigtails. And of course, these pigtails should have sterile caps on them. Keep this stuff clean. All right, the flow comes out. It goes past a flow probe right here in the prescribed place for you to put that flow probe between the 2 white lines just downstream of the clamp here symbol. But of course, you could put that anywhere on the arterial line. Don't ever put that on the venous line. Very important, because this is a flow and bubble detector. And even though it fits on the venous side, it has a different intervention than if you were to put it, the venous bubble. This has a different intervention than the venous bubble detector. So you don't want that intervention to happen for venous air. You want the intervention you're going to set to happen for arterial air. So we'll only put this on the arterial side. Goes past out of the oxygenator, past the flow probe, up the arterial line with the red stripes, past our simulated arterial cannula, providing some resistance. Looking at it from this angle here, we can see we've got a flow of 4.6 liters a minute at RPMs of 3,600. Our flow is greater than our RPMs, and that's a good thing. We have a negative line pressure on the venous side of minus 82, very, very traditional. And we have an arterial blood pressure, P-ART, monitored right here, have 282, also very normal. The delta P is 15 across the oxygenator, 4.5 liters flow, pretty normal stuff. Okay, so we're talking about pump failures. Let's start with the simpler stuff. Pump stop. What could cause this pump to stop? One of the things, there's 2 things that will cause this pump to stop: bubbles and pressure. The third thing would be some cataclysmic failure that you can't repair. But bubbles and pressure are things that you can address. So bubbles on the venous side, that will be hooked up to your venous flow probe, venous bubble probe detector, which is this one right here next to the sat-cret. If you have a venous-sided bubble detector hooked up there, and you can turn on an intervention. That intervention is called zero flow mode. Zero flow mode, if bubbles came down the line, would look like this. I can simulate that for you by pushing the S button and pushing this 0. And now it goes into zero flow mode. Watch, the flow is going to drop to 0. And in this mode, the pump has permission to raise and lower its RPMs as needed to keep the flow at 0. But since we have a bag up here, and it's not pulsing back at the patient, it doesn't have to do anything other than turn its RPMs to 0. Look, right now it just threw up 77 RPMs. I can increase the RPMs. You see them turn gray. They go to 3680, but they pop back to 0. I can turn them down, the gray, 3645, and they pop back to 72. So it is right now kind of going between 0 and 70 because it's in zero flow mode. If you ever get the call that, hey, my pump won't run, then certainly look for this upper right-hand corner, zero flow mode. That red light is on, then you're never going to get more than 0. And they can turn this knob anywhere they want. And it'll give them numbers for a moment, and then those numbers will go away, and it'll go back to essentially 0. Let's get out of that mode. Just press this once. Now we're out, and it's going to go back to the last thing it remembered, the last thing you did with that dial, which case, in this case, it was 3,685. Had you gotten scared and turned that all the way up to 5,000 trying to get the pump to run, it's going to go back to 5,000. So remember that. This thing has a memory like an elephant. Arterial bubbles would be another way that we could stop this pump. I can simulate that just by opening this door and letting it see some air. Or not. Okay, so we didn't have the intervention turned on. And therefore, it didn't do anything. Now, let's try and simulate this. We can open the door. And immediately, it sees the air here. And get a red indicator across the top, arterial bubble detected. You can see the red down here in the arterial bubble field. And you see red down here in the intervention screen. So we can go either touch the art bubble symbol or touch the intervention screen. It'll take you to the intervention screen. Or you can select reset. If you reset that, then you can restart that. So that's the software side of it. What's the clinical side of it? Don't do it that way. What you should do clinically is if your pump tells you there's a bubble, oh gee, I hear an alarm. My pump says there's a bubble. I should clamp the art line as soon as I can. Up near the patient as best, in case there's air heading up to the patient. Now I should check that out. I should look for air along the arterial side. I should maybe find the open bubble detector if indeed that's what it is. That's a super simple fix. If there was real air, I gotta walk it into the oxygenator. And I'm gonna pull it out through this port up here. And then when I've confirmed that the patient is safe from air, we can come over here to our screen. We can enter the arterial bubble setting. We can reset that, and then we can enter the information. Now it's ready to go. It's trying to get, it's going back to 3,685 RPMs, but it's zero flow because I have a clamp on over here. So let's turn this down to about 1,000 for a moment. So I'm not pushing too hard. Take the clamp off and come back up. Okay. You managed. We've talked about venous bubbles. We've managed arterial bubbles. If you had venous bubbles, you should walk them in and let them come out through the yellow cap up here. Take the yellow cap off. Set that aside. Doesn't need to be kept sterile. It doesn't have any fluid interface. And let the air that was in the venous line come out there. We'll talk more about that in another video when we do massive air embolus. So, bubbles, venous bubbles, arterial bubbles, they can stop the pump. Pressures. Pressures can stop the pump. There are 3 pressure settings here. The venous, the arterial, and the internal. They all have 2 limits you can set. Let's go into the P-art. And you can see you can set a limit for when do you want an audible alarm. Right now it's set to 400. And when do you want the pump to stop? 500. Now, air bubble on the venous side, if it sees a bubble, it turns off the pump, and it's not coming back on until you tell it to come back on. With pressures, on the other hand, the pump has permission to increase the flow again anytime the pressure is below that top limit. So let's demonstrate how pressures can stop the pump. Right now the limits are set to 400 and 500. I'm going to turn that 400. I don't want any audible alarms right now. I just want it to go straight to stopping. So I'm going to set this to about close to 0. And then let's set this 500 down to something we can easily reach, say 350. 327 sounds good. I'm going to enter that. We're at 287. We're getting a P-art above the warning limit. I set that to 0, so we're greater than 0, so we have a yellow alarm. And if we take a clamp and when we start occluding this line, then we're going to get over 327. When it gets to 327, ooh, nothing's happening. Why is nothing happening? You just saw me set it to 327. Because I didn't turn the intervention on. You see see the red link down here? Needs to be a red link up there. So I'm going to stop that for a moment. Let's come over here and let's turn on the intervention right there. Now we see the red link. The limits are what we set before, 327 and 0. The intervention is turned on. You know it's turned on because of the link in the text box. Now I'm going to start applying some resistance over here. When we get it over 327, it's going to turn the flow down to hold the pressure at no greater than 327. And if I release the resistance, we can get more flow. It's seeking out 327 again, but now it's going to give us 2.5 liters. If I tighten the resistance, it's having a hard time keeping it below 327, and it was complaining a lot. It was doing a little bit of surging there, where because of the way the interventions are set, it turns this flow down, then it's so far below that it ramps it back up again. And that surge, I've never seen that clinically, but we can produce it in the lab. So we always had flow there. I want to be convinced that the pressures can actually stop the pump. Let's turn this range down to 50, 44, that's good. I'm going to turn it down to 44 because this column up here of fluid pushing down on this gives us about 63, I think, is what I measured earlier. But I'm going to set the limit to stop at 44, and when we enter that, this pump is going to take its intervention. Now it's red because the pump has stopped, and it's telling us that the P-art is above the stop limit. Pressure is 63. I told it to turn off the pump at 44. And if we were to take this bag and lower it down so that it was less than 44 millimeters of mercury pushing down on this, then the flow would come up again. So let's raise this back up. So the moral of the story here is you could get called to the bedside because the pump won't run, and it seems unreasonable for the pump to not be running because you're expecting normal limits to be set in here. But if inappropriate limits are set, like stop the pump if the pressure is greater than 50, the pump's going to stop. And get a red bar across the top and you have zero flow. Hopefully your people in the room at the time interact with that in the proper way, that any time the pump stops, we need to get a clamp on the line. Clamp the arterial line. You could clamp the line over here, over there, it doesn't matter. Arterial bubbles, we suggest clamp the art line close to the patient. Just a normal pump stop, clamp it anywhere. You just want to prevent retrograde flow. So if any of those things happen, the pump to actually stop, you should apply your clamp, you should read the alarm, you should address the alarm. Manage the air, manage the pressure, manage the inappropriate limits. So if anything other than bubbles and pressure stop this thing, it's probably something that you need a new console for. If the brain fails, the pump might stop. If the motor fails, the pump might stop. If the disposable the disposable pump fails, well then you need a whole new circuit, and you get to keep the hardware. But we're practicing pump failures that are electronic in nature, and we're going to jump the pump to a hand crank, and then we're going to change out the console. So since we're moving towards the hand crank, let's take a look at the hand crank and understand how that thing works. This is a set of gears with a handle on it, and as you turn this, you're turning a magnet in here just like that motor does. It has a pin right here that fits in that hole right there. It's got a tooth at the top, and it's got a little lever on the bottom. So let's put this in. I'm going to turn it to the side for a moment. And you remember that when this engaged in the electronic motor, it engaged with a rotational clicking capacity. You put that in there, you turn it about 10 degrees and it clicks in. So of course, since they already taught you that skill, for the hand crank, when your head's on fire and you're really trying to scramble just to get anything done, they want you to learn a new skill. This new skill, this is not about locking it in with a rotational direction. You take that tooth and you put it in this slot here at the top, and then you rock this in underneath that tooth. So there's the tooth, here's the, and then that bottom part down there, you gotta manually pull that lever back, seat that, and now it's locked in. Tooth. Close it up. Release the pin. Locked in. Okay, so that's how that works. On top here, they show you some RPMs. A little LED light, just like they have on the top up here. They have an LED light there, so you know that when you're cranking it this fast, you have 2,500 RPMs. So let's walk through how we train for jump the pump and console change, hand cranking on a Cardiohelp system. When I'm the instructor, there's a learner, and they are doing whatever they're doing around the room, and when we reach that point in the competency where I need to test these skills, then I need to cause this pump to fail. And the easiest way to cause the pump to fail is to disengage it. The easiest and fastest is just disengage it from the motor. And you can do that with just pushing this one button. In fact, it's so easy, you probably ought to just know this, because it could happen in the ICU at any time. Because it's like one button and one little rock, and that pump is disengaged now. And our pump flow is going to drop to 0, and we're going to start getting alarms. So I come along, I disengage that and say, your pump has failed. And I hope that they do the very first correct thing, most correct thing, put a clamp on the arc line. And then while they're doing that, I come over here and I just turn the pump off. Do you want to switch off the system? Oops, I press and hold, I get the alarm. It says, do you want to switch off the system? I say that I do, and the pump powers down. And now we explain within the context of the training exercise that this pump has failed. You need a new one. That's down the hall. And you're going to have to go get that. So do whatever you do now. And what they should do is grab this hand crank and get ready to hand crank. You lift the door. You have to disengage the data cable. You have to disengage the SVO2 monitor. And put it up there for now just to get it out of my way. And you don't have to disengage the flow probe because the cable is long enough. It's the only cable that's long enough for this crisis. Bring this in, the notch into the tooth, rock it down, open the door, get that lock in place. You can drop this door again if you want. And if you turn it around into position, it should lock right there. Now we can flip the handle down and we can start cranking. Number one, most common mistake is happening right now. I've got 3,000 RPMs. Good things must be happening. Frequently forgotten, probably like 50% of the time in training exercises. Forget to take that off. All your data, which is, there's only one piece of data now, RPMs, your data says they're good, but there really isn't any flow until we take that off. So actually they should, when they flip the handle down, they should start cranking to about 1,000, then they should take the clamp off, and then come up to full flow. And they may, now I generally allow them to turn this into a 2-person exercise. And what we can do is say, if this is the person that knows how to operate all this equipment, then your skill is wasted cranking on this knob. Teach anybody to do that. You go down the hall and get your other pump out in the hallway. Hopefully it's very nearby. That good practice is that it should be like right over there. But don't send somebody who doesn't know what this is for it. Teach them how to hand crank. You show them 2 things. You crank this knob, to hold this green light right there at that number you tell them. I'm using 3,000 RPMs. 3.0 is what it says up here. And then watch the patient's pressures and saturations. Talk to the nurse. The nurse knows what this patient needs. Okay? So that's what they're doing. In the meantime, I've snuck around and disengaged just about everything. Just thrown it back in the box. And they're going to have to reassemble it, because in a moment, magically, their new pump is going to enter the room. It's hard to do with one hand. Blah. And you can unplug the power as well. Okay, we're pumping. That's the new pump now. This is the new pump. You're still hand cranking. Let's get this thing fired up. It comes in the room without any of its electronics. Let's grab the, if we want this venous flow probe to calibrate for us, we need to hook it up first. Because when we power it on, it needs to be mounted right there. At this point, we can push the power button and let this thing start to wake up. While I'm here, maybe I'll plug in the power. And keep cranking. Take my data cable, plug that in. The flow probe. You woke up. It's reading a flow because I have a flow probe plugged into it. Says I'm pumping 3.6 liters per minute. It doesn't have anything else. It's got a bunch of snake eyes in all the other columns because it's not plugged into anything. So let's jump the pump again. Jump it off of the hand crank and back onto the new main motor. So I'm going to reduce my RPMs to 1,000. Put a clamp on the art line. Put it in, lock it in place, hook the data cable up since I'm right here, and generate some RPMs. Get my 1,000 RPMs, take the clamp off the line, we have flow. Come up to full flow. I have pressures. Because I hooked in the data cable. What I don't have yet is the SVO2. But it's not alarming because it's on the docking station and is happy up there. If I disengage this, may be able to get something to come out of it. There's a button down here for releasing this pin. And there we are. Successfully managed a pump failure. Jump the pump to a hand crank. Boot up a whole new system. Jump the pump back from the hand crank to the new console. I think you could do that with a little practice.